unmute yourself and also open the video, please.
Good afternoon, Rima, and good afternoon, Professor Silverman. Good afternoon to all the attendees. From London is good afternoon, but good morning, good evening, depending on where you are. Shall I start by sharing my screen?
Yes, please.
Sorry. Hope you can see the first slide.
Yes.
Hello.
Yes. So I can see the screen, and as we said, we're going to talk on the basics, and then go a little bit on advanced on the fetal Doppler in this talk. Thank you so much.
So it seems to be cut off on the main screen.
Yeah, sorry, I haven't moved yet because I wasn't sure that you could see my slides. So today I was asked to talk about Doppler, the basics, and the congenital heart disease, enormous congenital heart disease. So first of all, I'd like to thank you, particularly Rima, for inviting me to take part in this webinar. I've known Rima for a long time, longer than either of us want to admit. So to start with, I have no disclosures to make and no conflicts of interest. So I'm going to try and cover a brief outline of basics of Dopplers and different modalities, and the Doppler, how to use it in normal heart, and then finish off by using post-wave and color Doppler in congenital heart disease. So can't cover absolutely everything, so I'll try and do a more general aspect and specific aspects from simple to more complicated cases. So I'm going to group the Doppler basics and modalities with the normal heart to explain how I use it and perhaps give some hints for the audience. I believe there probably is quite a wide level of people attending. So this is really very, very basics, but it's still, people starting in their fetal medicine or cardiology sometimes need a bit of a reminder that the color flow is color coded for direction, and red is towards the observer, towards the probe, and blue away from the observer. And it obviously allows assessment of blood flow direction and velocity as well, but also is a great help for patients where there is technical difficulty in scanning, either because of the mother or because of the fetus. So also important is to differentiate the use of color, cardiac Doppler and obstetric Doppler, because the velocities are different. So there are a number of parameters that are very similar. Is flow direction, is qualitative for flow velocity. We can't give the absolute value. It's angle dependent, at least the conventional color. But the main difference is the cardiac velocities. The cardiac velocities are higher intracardiac, around mid-gestation, somewhere around 50 to 70 centimeters per second, while the veins are more similar to the obstetric velocities, around 20 to 25 centimeters per second. And this is very important because otherwise we don't obtain the information we are aiming at. So other important thing is to know how to optimize your color. It's not just pressing a button and then everything comes nice and easy in most patients. So I think usually the most common button that we change is the velocity range, or the PRF, but also important flow gain, the size of the box. I'll come back to the transducer frequency and color filter, which I don't use very often, but sometimes we may need to adjust that as well. So velocity really determines the sensitivity of the color signal, and you adjust the PRF, which is the velocity range, and this will dictate what kind of pattern or flow pattern, color flow pattern we're going to see within the cardiac structures without achieving aliasing. Aliasing is going to be turbulence, and that's going to be dictated by the velocity that we choose to set at the machine. So aliasing, we can see here demonstrating within the cardiac structures and the full chamber view, if we set the velocity at around 70 mid-gestation, we have a very smooth color, which is laminar. But if we change the velocity deliberately to look at pulmonary veins, we have a laminar flow in the pulmonary veins, but the intracardiac velocities, we cannot interpret them because we have velocities within here which are higher than the velocity we set in our color scale. So this is very important because we have to modify that as we're scanning the fetus. So if we start from lower in the abdomen, I always start doing the ductus venosus because this is part of the fetal circulation in the assessment of the fetal heart. And we can see that if we set the velocity for veins, which is around 28 centimeters in this case, we can see the umbilical vein very clearly. We can see the hepatic veins, and that facilitates visualization of the ductus venosus because its velocity is the highest in the venous circulation, usually around 50 centimeters per second. And this makes it easier to identify the ductus venosus and to pulse-wave it if needed. Similarly, within the arterial system, the vessel that has the highest velocity in the fetal circulation is the arterial duct. So whilst here we have normal color flow pattern across the pulmonary artery set here at 57 centimeters per second, we have aliasing across the arterial duct. So we don't know if that's normal or abnormal. We would have to pulse wave that to actually get the absolute velocity across the arterial duct. Since this is relatively small, that's probably within the normal range. So another consideration when using color, which I think probably is overlooked in many instances, is to know that you can adjust the frequency of the transducer separately from the transducer that you pick up, that you choose to do the scan. So if we have a high BMI, polyhydramnios, late gestation, which was a low frequency probe, when we set the color, we still have the option within the patient, within the same probe, to select a higher or a lower frequency, and that can optimize and can make a big difference to how much information you can get from the color. So transducer frequency here, I'm saying that within the use of color. So if you have a very, if you look at very low velocity, the patient is easy to scan, it's better to increase the frequency of the probe or the setup of the probe to obtain more sensitivity on the color. Contrary, if you have a difficult patient and you're not getting color information, you then switch to a lower frequency within the color setting, and that would allow you to get more information and to also assess higher velocities. So I put these three images here to show that color can be very useful. Although it's not yet incorporated into ISO guidelines, for example, for screening, a lot of people are using more and more color, and I believe that a lot of people in this audience do probably use color regularly. So this is a short sweep here from the left ventricular outflow tract to the 3-vessel trachea view without color, and these are new modalities which have a 3D effect. So most of the manufacturers are moving towards that. You have the option of switching on this special modality. It doesn't usually give you the velocity range, but it's quite nice. It looks a little bit like blood, but it takes a bit of time to get used to the information you obtain from that. I quite like the use of power Doppler. This is a bidirectional Doppler, and you can see here that we can easily see the bifurcation of the pulmonary artery. So it gives a lot of extra information. So I'm going to do 2 sweeps through the normal fetal heart to show the use of these. So if we start with the velocity, which is the intracardiac velocities, you can see in the abdomen, if I stop here, if we start from the abdomen, we see some of the veins, but we don't see very easily the ductus venosus. When we come to the heart, the color is laminar, and we can see that the velocities across the pulmonary and the aorta are within that range, because otherwise it would be aliasing if they were higher than that. So we can see just in the color that these valves have normal function. Contrary, we do use lower velocity as well, and if we do the same sweep at 24 centimeters per second, we can see here that we still see veins, we see more of them. We see the venous hepatic veins as well. We see the ductus venosus, and we highlight, excuse me, much better the pulmonary veins coming to the left atrium, but it's a complete color mix within the heart, within the intracardiac structures here. We can't really interpret that very well, and we cannot judge the velocity across the great arteries. So just knowing that difference is very important to be able to interpret the information we are obtaining. So I think it's important as well to start doing in the normal heart more than just that level, the 3-vessel and trachea view, and going through levels above that. And here we see the three-vessel view with the pulmonary artery, the transverse aortic arch, and the trachea. And if we go a bit higher, because people are moving more and more and obtaining more information, we start to see above the level of the innominate vein, these two arches that run from posterior anterior. These are the internal mammary arteries. They are branches of the subclavian arteries. And here we have the innominate vein. And these internal mammaries, they delineate the thymus, which has been described by Palladini some 10 years ago. And this is the innominate vein. So this is very important to do this even in normal patients, because when we come to patients where we suspect, for example, 22q deletion, it's important to assess, is the thymus present? So the more we do that in normals, and it becomes very easy if you do that on a regular basis. That's the reference from Palladini. It's 10 years ago since he described this. And also, there's a lot of information to obtain about the subclavian arteries, which initially was particularly the aberrant right subclavian linked to potential marker for chromosomal abnormalities. But actually looking at the subclavian arteries is very important, because now we are diagnosing a lot of vascular rings, and knowing where the left subclavian artery comes from is very important to determine the morphology of the arch abnormalities. So here we see the innominate vein. This is the right side. Comes here the first branch going to the right arm, and this is from the left side, the left subclavian. So all of this information is there, and is in most patients relatively easy to obtain that. Some patients, obviously, like everything on scans, you don't get it so easily, but it's good practice to start looking a bit beyond the level of the three-vessel trachea view. And that is the trachea on the left aortic arch. Now, something else that I've been doing for a number of years as well, and I've shown that in some live sessions and got a couple of publications on that, is the color. You have a balance between the gain, the priority you give to color, or to the 2D image. So something very simple to do is to reduce your gain on the 2D image, because that brings out the information for the color. Like in this one here, you can see very nicely the inferior vena cava and the aortic arch, just by simply turning down your gain. Sometimes in some machines you have to reduce the TGC as well to get just the color information. That's why I named it just flow technique. So you don't need anything special. So a little bit on spectral Doppler. Again, there are lots of controls that one can use, but spectral Doppler concentrates on one particular area, which is where we put our sample volume. So we choose where we are sampling the specific velocity, and the information is numeric. So it's not like color that just gives a qualitative information. In cardiac Doppler, it's more important to know the velocity rather than the PI, which is the common measure in the obstetrics. So therefore, the angle of insonation is very important, and we should try and aim to get an angle preferably less than 20 degrees. So again, the same apply for the Doppler. We can change the frequency of the setting for Doppler to obtain higher velocities if we use a lower frequency. And more important as well, I think this is still seeing avoid duplex and triplex. Most machines have an update button which improves the quality of the information. Here I'm exaggerating, but just to show what duplex is, you're asking the machine to show you a 2D image moving at the same time to display the spectral Doppler. You can see that the signal is not good. It's difficult to get the information. It's not smooth. And here's triplex. We have color, we have 2D, and we have Doppler. So this should not be used because the quality of the signal is not good. Instead, we should, when you show the spectral Doppler, this image should be frozen. You choose where you are, you update your button, and you just display. And that's the normal waveform through the tricuspid valve, in this case, biphasic, a nice envelope without too much gain. So all these are technical details, but are important to reproduce our measurements. Just going to go through all the cardiac valves. And in this case, we got good angle of insonation for both the tricuspid and the mitral valve here, very clean signal with a biphasic E and A waves. And also in this one, we can see a perfect angle for the aorta. So without doing too much, you can get 3 of the Dopplers. But in this case, if we want to do the pulmonary artery, it would be crossing here. So the angle would be incorrect. So of course we have to move, And this is for more or less a sagittal view, where the left ventricle is here, the right ventricle coming through here. So now we are in almost 0 degrees to the pulmonary outflow tract. So we get the highest velocity and the most accurate velocities. So very important to keep this in mind too. Now, still part of the pulmonary circulation, the fetal circulation is the assessment of the pulmonary veins. I routinely do pulmonary artery and pulmonary venous Doppler in every patient as a means of assessing the rhythm. And this becomes important as well in cases where we have like hypoplastic left heart syndrome, because we want to see if there is a restrictive foraminal valley, and that information is coming from the Doppler in the pulmonary veins, and also in case of autonomous pulmonary venous Doppler. So if we do that on a regular basis, is a lot of information that we can obtain. So basically the signal here is pulmonary vein and pulmonary artery. This is atrial systole, ventricular systole, diastole, and this is ventricular systole with the vessel going into the lungs. So you can kind of correlate this more or less with an electrocardiogram, like a P wave and a QRS complex. You can also measure the PR or AV interval. And again, it's very useful to my experience in assessing fetal arrhythmias, and that's a reference. I've described this some 14 years ago. And finally, still the post-wave Doppler in the ductus venosus. Obstetricians were used to that. I don't think it is yet common practice amongst cardiologists, but I would encourage everyone to do that on a regular basis because it is part of the fetal circulation. So that's a very brief basics of Doppler and use in normal hearts. So I'm going to try and give some examples of post-wave and color Doppler in congenital heart disease. I can't cover everything, so I'm going to start more or less from the abdomen, going up towards the upper mediastinal and more simple lesions to more complex lesions, just to give an idea of how much information we can get from that. We cannot do a fetal echo without using color flow. So here's our norm as a reminder of the ductus venosus that comes through the umbilical vein. Some of that goes through the liver, continues here, it narrows down and it joins the suprahepatic portion of the inferior vena cava where it receives the hepatic veins. So this is a case where the ductus venosus is absent. We see here the umbilical vein coming, it turns to the portal system, that's the left portal vein, and then you don't have that connection with the inferior vena cava, and then you have all the hepatic veins coming back to the IVC. So this is an absent ductus venosus with intrahepatic drainage. This does not usually cause any hemodynamic problem because there is no overload of the fetal heart, but there seems to be association. Of course, it can be a variant of normal with genetic syndromes and chromosomal abnormalities. For example, if a fetus has an increased nuclear translucency and has an absent ductus venosus, I think that makes it more likely that potentially there is a genetic syndrome, in particular Noonan syndrome in my experience. So it is part of the assessment of the fetal heart and very easily seen with color flow. There's another fetus where the ductus venosus is anterior here, umbilical vein coming. You can see there's an abnormal course and it joins the inferior vena cava. In these cases, there can be a little bit of volume overload because it kind of, sometimes you don't have the ductus venosus in its usual position and it doesn't go into the left atrium, it goes into the inferior vena cava in this case. This fetus happened to have trisomy 21, also had a ventricular septal defect. So moving from the abdomen to the level of the full chamber view, I chose here a very simple lesion. And if you look at this one, it looks an absolutely normal four chamber. We have a good angle of insonation here for the interventricular septum, left side lowermost, right side uppermost. And if we put the color, we can see very clearly, with low velocity, there is an apicomuscular ventricular septal defect. It's optimizing to see the lower velocities down here. You can't really interpret the intracardiac velocities. So it's more apicomuscular VST. And then we might say, well, is it important to pick up these VSTs? I don't think we spend a lot of time looking for small muscular VST, but once it is detected and more we get referrals for small muscular VSTs, we do need to check the entire heart. Not infrequently can be associated with coarctation, for example. It's important to check the aorta, to check the whole heart, but in particular the aorta. In this case here, and not the same patient, also was referred because of a muscular VST, which I think you can just see here. But as we're assessing the pulmonary veins, we have the left atrium down here. Pulmonary veins, we can see one from each lung coming here to the left atrium, but there is another vein from the right lung going directly into the right atrium. So associated with the small VSD, we have a partial anomalous pulmonary venous drainage. So as a minor abnormality sometimes leads us to diagnose something that may or may not be important. Now, coming back to color and the aliasing effect, it can be very useful to highlight turbulent flow, particularly at the screening point. So I'm going to give you some example of valvular aortic stenosis. And just as a reminder, this is the left ventricular outflow tract. The aortic valve is nice and mobile. It opens in systole, and you don't see it in diastole. The color should be nice and smooth. This is a velocity of 70. We don't have any turbulent flow. It means the velocity is within that range, so lower than 70, which is normal for mid-gestation. And I think it's very useful. I don't know if you have come across, but there are now Z-scores for velocities across gestation. And I just picked up one here from the ascending aorta. This is the reference. Roughly, as a rule of thumb, it's less than 1 meters per second, so around 80 centimeters, around 22 weeks, and about 1.5 meters per second around close to term. So there's a rough guide, but sometimes you want to know, is this abnormal, is this not, what's the Z-score? And that is on this page that I think is becoming very popular, and you can do the Z-score for Doppler velocities as well as biometry. I find it quite useful. So this was a referral of a fetus that had a dilated aorta at the level of the 3-vessel view. And when it came to me, it wasn't quite in the best position with the spine posterior, so we don't see here the 3-vessel view, but we're seeing the color already, which is set up at 100 to try and get rid of that aliasing. And you can see that it's not, even with a velocity of 100 on a 23-week fetus, we have a lot of aliasing here. That's the left ventricle, the left ventricular outflow tract, which means that velocity must be higher than 100 centimeters per second, which is indicating aortic stenosis. The dilated aorta is better seen here in a sagittal view of the aorta. That's the center of the heart, the aorta coming here. The aortic arch itself is unobstructed, so this is post-stenotic dilatation. A closer view of the aortic valve, if you compare to the one I showed before, it doesn't disappear in systole, it looks thickened. And when we look at the velocity, it was approaching 2 meters per second. So this was evidence of mild to moderate aortic stenosis. We know that this can progress sometimes quite quickly in pregnancy. This one progressed very slowly and was still kind of moderate towards the end of the pregnancy. So it did not need any neonatal intervention, but sometimes they do. On the other side of the heart, we have valvular pulmonary stenosis. Again, quite often these cases are referred because the pulmonary artery looks dilated, and you can see here in the 3-vessel view is a still image, a larger pulmonary artery than the aorta, much larger than you expect. This one, we put the color flow on a velocity range of 51. We can see clear aliasing across the pulmonary outflow tract. And when we measure the velocity, that was abnormal for a 21-week fetus. And this baby had, at this stage, mild, relatively mild valvular pulmonary stenosis. Again, without the color on the screen, sometimes this may not be noticeable. Moving a little bit higher, and I'm not going to concentrate on this too much, but John, I think, is part of his topic. With the introduction of the 3-vessel and 3-vessel trachea view in particular, we have been inundated by babies that have a right aortic arch. Seems to be one of the most common abnormalities that we see every year. And this is a typical example. In this one here, we can clearly see the demarcation of the thymus. We don't need the subclavian artery and the internal memories here, but sometimes we do. So this is the right side, this is the trachea, that's your ductal arch to the left, your aortic arch to the right, and the SVC. So this is clearly a right aortic arch. What is important is to know, does this constitute a vascular ring? And most of the cases that we see with the right arch on the left side of the arterial duct will have the subclavian, like in this case here. So at the level of the innominate vein, we have here the internal memories. We can see the vessel going to the left, the trachea is here. Behind the trachea, going towards the left arm, so an anomalous left subphalangeal artery. So that combination does constitute a vascular ring. It's not clear if the babies will be symptomatic or not, but you can say pretty confident that the chances of having a 22 deletion here is low, because you seems to be a very well-developed sinus. Doesn't exclude, but it's very low. So I'm going to make it a bit more complicated now. It's still within the heart, a case of tricuspid atresia, and I decided to put some diagrams here so that you can follow the images that are to come. So we do need to use sequential segmental analysis to hearts that are more complex and just like simple VSTs or tetralogy or transposition. So this is a case of absent right AV reconnection. So we have the two atria in the normal position. There's no valve at the tricuspid valve. There is one big ventricle, which happens to be the left ventricle, a smaller right ventricle, a ventricular septal defect, and the vessels are in a discordant position or transposition. The left ventricle giving rise to the pulmonary artery and the right ventricle giving rise to the aorta with an additional coarctation. So quite a complex heart. So on a sweep here from abdomen to the upper mediastinum, we can make the whole diagnosis without the use of color. And I think using color does not mean we should not look at the anatomy on 2D. It is still very important to use the cross-sectional image to look at the details of the valves, to look at the details before we apply color. So in here we can see, I think I broke it down. We start from the abdomen. We have the stomach on the left, depending on the baby's position, aorta on the left, IVC on the right. So this is in keeping with cytosolids of the usual H2 arrangement. When you go into the full chamber view, there is no valve. There's an absence of the right atrioventricular connection. The right atrium, left atrium, mitral valve going to a ventricle here. The left ventricle happens to be. So there's tricuspid atresia. If we move up towards the vessels, we have the left ventricle here giving rise to the pulmonary artery. Notice there is a little chamber here, anterior superior, and that is turned out to be the right ventricle. And when we move up in the mediastinum a bit more, we can see the aorta arising from that smaller right ventricle. And it does suggest as if there potentially is a coarctation. So the diagnosis can be made and should be made, if possible, on a 2D image. But of course, the color information will help and also will facilitate seeing things that sometimes are not visible on a cross-sectional illustration. So that's the right atrium. You can see flow here coming from right atrium to left atrium, then goes into the left ventricle. Let's start again. Left ventricle here goes into the aorta, flow across the ventricular septal defect into the smaller right ventricle, and from there it goes into the smaller aorta. Maybe I will just I was trying to do it slowly, but it failed. So on a sagittal view here, we can see very clearly the larger pulmonary artery, which we've seen coming off the left ventricle with a small aorta, and indicating also an area of coarctation, which is transverse arch hypoplasia, possibly a localized coarctation. So this gives the information that we probably had without the use of color, but it's nice to have that documentation of the physiology, and it does help, particularly for the aortic arch, getting more details of the anatomy. But that's not the case for other abnormalities like pulmonary atresia VST, in which the use of color is essential because we need to determine the source of pulmonary blood supply. So we start here with a long axis view, right ventricle, left ventricle. We have an overriding aorta, pulmonary atresia, and there was no pulmonary artery. So we do need to determine how is the blood getting to the lungs, and for that, the use of color is essential. And you can see here, we have the aortic arch, large arch unobstructed on a sagittal plane, and at the same time you see reversal flow through the duct. So this is duct-dependent lesion, which is information that we need in order to counsel the family, in order to discuss management, and in order to manage the newborn baby. This is from the same fetus at 20 weeks. Also important to see, can we see the branch pulmonary arch in this case, because that's important for counseling. And without the color, you can see here, but it's confirmation that we see the right better here, but on the color, we can see the left pulmonary artery as well. It happens to be a right aortic arch. So we know that branch pulmonary arteries are confluent. So another case of pulmonary atresia. We see here ventricular septal defect, an overriding aorta. And in this case here, you can see some vessels at the level of the four-chamber view behind the left atrium, one heading towards the right lung, one heading towards the left lung. So the first thought is these are mactas. So sometimes they're very small and you can't see without the colors. In this case, I think we could see them, or at least think of them without the color, but it's important to follow them. Of course, we can't see the intraparenchymal vessels. These babies do need a full workup after birth to determine the true division or the true ramification of the collaterals to plan surgery and to perhaps unifocalize. But in some cases, if they're large collateral like this one, you can actually get more information. And in this case, actually, I'll show you here that the two vessels were not mapica. One appears to be more of a duct, comes here the aorta in the course of a duct, and it runs towards the left lung. This is left, this is right. And there is a separate collateral mapica from the descending aorta. So although it could have been all mapicas, in which case we don't need to start prostaglandin, in this case, there is the left lung supplied by a left duct. So this is also a duct-dependent lesion, although it has a mapica, and it probably is going to go into heart failure because of two large vessels going to the lung. Now we are coming towards the end, a very complex case, and also I think I'm very interested and been doing early scans for a long time, and color is even more essential on early scans. I think this is a very clear 15-week fetus with family with history of congenital heart disease. We have the right ventricle here, the left ventricle is a long axis view. We can see here clearly there is an overriding vessel, a large vessel. Is this an aorta? Is this a truncus? And then if we go to the next image, we can see here a little bit higher up, that transverse view. And I put it still here that this is actually a truncus arteriosus. There's a right arch, that vessel coming here. So we don't always get that degree of definition, but unless we try, unless we optimize the color, we don't know. And if we do that, we will get more information. So that's why I think it's important, coming back to the beginning of the talk, to know how to use the color, to understand what the velocities are, to explore what the machine has to offer, to use frequency of the probe, not just the velocity and the gains, because we can optimize the image quite a lot. So this was a truncus arteriosus. So I'd like to finish by showing this slide and saying, you know, we can get a lot of information on 2D image, and black and white photography is actually quite nice. But I think if we add color to the heart, we do get additional information, and perhaps we see some things slightly different. And of course, we can do the two things. We can split the image and look at the information with or without color. But if you're not using it at screening level, I think it should be encouraged. If you are an obstetrician moving to cardiology, just be aware that the settings are different and know how to interpret the color and the pulse wave Doppler as well. And know your machine, because the machines do have slightly different names they give for the same controls. And thank you very much for your attention.
Thank you so much, Delaney. As usual, beautiful images and beautiful explanation of the images. We have two questions, but also since we're talking about the basics and this one here, I was just wondering, we need to know more about the tricks that you use when I know because I've attended your sessions a lot. So you have summarized that you wanted to make sure the 4 or 5 aspects when everyone is adjusting the image. So the color is important, the frequency is important, the transducer is important, but which is the most important one? To me, at least, is the proper 2D is the most important before we go into color and Doppler. Do you agree to that?
I think I made that point in one of the slides where, you know, the one with the tricuspid atresia, the point was we can, with the 2D, without the color, make the complete diagnosis in most fetuses. So that was an easy to scan baby. So I had a whole sequential diagnosis without the color, but that's not the case for all fetuses, as we know. Some of them are more difficult, so they are complementary, but I don't think the color should be used instead of the 2D. We do need to try and get the details, you know, the details of the valves, how they move, are they thickened, Do they have short chordae? Those details you don't get from the colors, so they are complementary. So if you have just one to do, I'll try to do just 2D because it gives a lot of information. But we do have the facility to use both colors and not just conventional color, power Doppler, high definition, all sorts of new modalities which add a lot of information. So we need to understand them the best we can in terms of clinical utility. I think the physics is becoming quite difficult to understand how they work. Just the power Doppler, for example, is quite old already. Power Doppler is not used that much in the fetal heart. It's less angle dependent. So we get additional information. So if you're not getting color, you change your frequency of your transducer to get more information. And if you're not getting with a conventional color, use the power Doppler. I use all the modalities the whole time, depending on what I want to look at.
I think power Doppler is coming. I mean, a lot of people are using. I know Dr. Huta, who trained me, is using a lot of power Doppler. I don't know, Professor Charlotte, what do you think of the power Doppler in the imaging?
Hi, I have to say it's not something I use very much. I think we use most of the things Jelani has described, but we're not really using power Doppler. I think it seems to be more people who are working in obstetric practice maybe are using it more. I think most pediatric cardiologists and fetal cardiologists obviously may use it from time to time, but I don't think they're using it that much. I don't know if you agree with that, Jelani, but
I don't know about other people. I use it the whole time.
Yeah. Well, we don't use it
I
very
just switch between the two of them.
Yeah.
I mean, so the difference is because the power Doppler will show you things that the normal color will not show you. Is this the message?
Well, the power Doppler is angle independent, Rima, while the conventional color, if you are off angle, you may not get the signal that you want. You may have to reduce the velocity quite a lot to get the flow information. While with the power Doppler, you overcome that limitation. As I said, the for small vessels is quite good.
Yeah.
For the aortic arch, I think is good. There are different, there's a mixture between conventional color and power as well. The high definition, for example, is a kind of somewhere in between. Everyone is using high definition.
High definition we use a lot of, yeah.
Actually, I think a lot of people are using high definition instead of conventional color, which is a mistake because you cannot appreciate the aliasing using high definition. So I think the two of them, if you're using high definition, you should do a sweep first on normal conventional color because you can spot aliasing that you cannot spot very easily on high definition.
But I think you've both made a really important point already, that it's really important to look at everything with the 2D imaging first and make a full assessment, and then use the color or whatever Doppler you're using to supplement that and get more finer details. But I know I have watched people and they sort of put the color on quite soon without really looking at what the 2D images are showing and what the actual structural problem is. So you've both made that point very nicely already.
Back to the master of ultrasound, Dr. Silverman, what do you think of this?
Well, I think that Jelani Dr. Carvalho did a great job. I thought the images were all wonderful. I think the argument that she makes for the use of color Doppler in general fetal ultrasound, fetal cardiac ultrasound particularly, is the important issue. You can't practice decent diagnostic stuff without the use of color Doppler. And I see a lot of people that are not familiar with the color Doppler technique, particularly the non-cardiology group of people that try to get away without using Doppler color flow. And I think Jelani showed the power of this technique when you look at things like anomalous pulmonary veins, additional sources of pulmonary blood flow, the intrahepatic connections, etc., etc. There's no way that you can get away without using Doppler color flow. And I think that is the most important message here. Of course, I mean, I could not argue with anybody about the fact that we have to use all of the modalities of ultrasound. Perhaps one of the things that we need to mention and think about it is that the saying in Doppler physics is one man's signal is another man's noise. Maybe you could say one person's signal is another person's noise. And the one beauty of the Doppler signal is that it's a thicker signal in slice technology than the 2D signal. And so, particularly in the fetus, where you may be slightly off angle with your two-dimensional image, you'll get a better example of the real anatomy from the Doppler color flow than you will from the image. And I always encourage my undergraduates to look at the two-dimensional image rather than the color Doppler, because psychologically, your eye tends to go towards the color image rather than focus on the black and white image. And I always say, well, once you've got it in there, then you need to really focus on getting the two-dimensional image correctly. I only have one other point that I think that Julani has made, but I think it's very, very important. And that is that when you look at what the peak velocity is, and the angle of the structure that you're imaging is off axis, that the velocity may be substantially lower than what you see. And this can be used to advantage as well as disadvantage, because you really have to resort to a pulse Doppler or a continuous wave Doppler to actually work out what the velocity is. And again, Julani mentioned this point very, very clearly, is that you have to have, in order to work on the velocity, an axial alignment of flow to the transducer. And I think those are the only important points that I wanted to make. But other than that, I would like to congratulate Julani on managing to take the whole aspect of color Doppler and condense it into 1/2 an hour presentation.
Thank you. But before we leave this, you mentioned the numbers in the Doppler. That's very important. Now, Julani, it was beautiful, the graph that you showed, 0.8 meters per second for ascending aorta, early gestation, but I'm not very sure of the 1.5 meters per second in the late gestation. Is this something that we can depend on? I'd like to get the idea of the panelists for that. 1.5 in the graph that you showed from the American Society of Echo.
Charlotte. Yeah, I think I would accept, I think the Doppler velocities have changed over the years in terms of what we accept as normal. When we started off, we used to say anything above 1 in later gestation was something to worry about. But I think with the changes in our machinery and the way we do our scans, we do accept higher normal levels. So I think 1.2, 1.3 at scans at 32, 33, 34 weeks we often see, and I don't think that's actually abnormal. But I think you have to put it into the context of everything else you're seeing. You can't take a Doppler velocity in isolation. You need to think about what structure you're looking at. What does the valve look like? Is there something else you're worried about? So I think just to take one thing in isolation isn't a good idea. The other thing I often do is sometimes compare the two sides. So if I'm doing arterial valves, if you've got a high velocity, 1.4 in the aortic valve, but the one in the pulmonary valve is sort of 0.7, 0.8, and you've got good angles on both, then I start to think, well, maybe I should be worrying about this one. I mean, that's very arbitrary, but that's just one of the things. But I think generally we are accepting slightly higher velocities as being normal. I noticed John's just come on. I don't know if John wants to comment on that. John, are you there?
Hello, John. It's a pleasure and honor to have you on board. I know that you have a busy clinic. Thank you for coming.
Morning,
yeah,
John.
sorry, I was a bit toing and froing on things, but I agree with what Gerlina said. I think you can compare both the valves. I also think you have to look at the Doppler signal itself, because very often on the pulse, you'll see a very neat signal with a very, you see a nice envelope and you don't see too much variability or if turbulence, and you can look at the actual Doppler signal and it looks a pretty uniform signal. So I think you can look at that. I think you can compare the valves, and I think you need to look at the valve and ventricle of the corresponding side and put it together.
But the number, the 1.5.
1.5, I think, is a little high.
Yeah.
You probably, we've just published on a whole series of over 7,000 cases of normal velocities, which has just been come out in JACE on looking and with Z scores to look at what is average and how far above and below. So clearly you will get cases above and below. I think 1.5 is getting up there at any gestation.
If I may say, that velocity from that, I took that from the graph from data that has been published. That velocity is at virtually at term.
Yeah.
We're not talking about velocity 32 weeks. 32 weeks will be high.
No, that's great. I didn't see the slide because I've only just joined, so I'm kind of slightly blind on that. But
early gestation 0.08, late gestation is the 1.5.
The late gestation
late gestation right at term, I think.
That was around 39, 48
to 30.
I think that's actually a good point, because also not many people have got large data on velocities near term. I mean, when we have all these normal ranges, the number of fetuses that you get down to in the late gestation goes down quite significantly compared to what you have earlier on. And I think there's probably much wider variability in what you're going to get.
But also, if you're scanning a fetus for whatever reason, at 38, 39 weeks, if you did get a velocity of 1.5, and if you think of the velocity in the neonate, you wouldn't be too worried about that velocity, at the 39-week fetus. If the aortic valve looks normal, if everything looks normal.
I think that's the point. If the aortic valve looks normal and the ventricle is normal, then no, you wouldn't. It's just, it just depends on the full assessment on whether you're seeing anything else.
The bottom line, the gradients are not very, very informative. So we can say gradients in fetal hearts are not very informative. You can have stenosis without a gradient, and vice versa. You can high velocity flow without any stenosis in 2D. Is this the right message, or I'm over simplifying things?
The velocity will depend on the size of the valve, will depend on the cardiac output. We know that you can have a poor function and not have have stenosis and have a low velocity because you have lower cardiac output. You can have a relatively normal velocity in a fetus that suspect coarctation, for example, where there is less flow going to the left side, clear disproportion. So your cardiac output, your stroke volume on the left side is less. So if your velocity is 85 in a fetus with suspected coarctation, and your pulmonary velocity, as now we always compare that as well, your pulmonary velocity is 60, the aorta looks small, that velocity of 85 may potentially mean a bicuspid aortic valve, even if you plot the value, it's normal. So the number, like everything in biology, you don't take just one measurement. That's a rough guide, so you know where the velocities are, but you have to put everything together in context.
Yeah.
You can't just read them one, unless the velocity is 3 meters per second and it's clearly abnormal.
Yeah. But the same applies to other things, like tetralogy fallow. You can have significant right ventricular outflow tract obstruction, but with a normal velocity. So I think in the fetus, the velocities are not telling you the full picture. You have to look at everything.
This is in contrast to postnatal. That's a very important teaching point here, that velocities antenatal do not correlate with what we see postnatally because of different physiology and the way the valve is shaped. Joan, I know that you're busy, so I'm very glad to see an old friend on board. Actually, me and Joan used to be maybe a few years back registrars together, and our mentor was Professor Sharland, but we don't want to talk about age now. And so, yeah, exactly.
There's one other thing about the normal data that when we look after patients after birth, we make sure that they're in a basal situation. And I don't know that it's actually possible to look, and I've never done this, to say, is the fetus active or is the fetus not active? Because, just the slightest change in cardiac output is going to change velocity that you see. And you always have to think of that as a consideration.
I don't think cardiac output changes that much. with the
if
fetal
they're moving
movement.
a lot, if they're moving a lot, you may measure 95 and then you say, okay, let's wait until the baby's quiet. You measure again is 80.
Right.
Is it related to what, Mom?
With respiration as well, with breathing movements,
okay.
not respiration, but the breathing movements.
Exactly.
So it's all physiological. It will change. It's not static.
Yeah, but
and then angle is very critical in making those. I don't know whether that is actually considered in the normal data. John, what is your issue with the 7,000? Were they angles all under 30 degrees or under 15 degrees?
Under 30. They're recorded prospectively, and we generally wouldn't record if you're getting to more than 30 degrees.
Mm-hmm.
I mean, nobody sits and does the angles in actual practice, but they were done prospectively. So they are sort of as patients came through, rather than going retrospectively back to the better images. But we only record if we think this is a reasonable clinical measurement. If it's baby's in too bad a position or something, then it's not something we would say we record on the system.
But you can also bring the patient back if you're not happy, rather than making any conclusions prematurely.
That's correct, but what I'm saying is I don't think you probably what we tend to do is to record data which we think is representative rather than data which we think is rubbish, for want of a better term.
Okay, we can move to our next speaker, Professor John Simpson, who is very well known, and he's going to talk to us about vascular rings and very important things. I don't know exactly, the talk is going to be very interesting. John is a professor of pediatric and fetal cardiology at Evelina Children's Hospital, and also he has published over 200 papers and textbooks and presented widely, particularly echocardiographic imaging of congenital heart disease. Professor Simpson is lead author of the textbook Fetal Cardiology, Practical Diagnosis and Management, published 2018, so you better go and read it. I haven't read it yet. He's the president of the British Congenital Cardiac Association. Welcome on board, John.
Thanks very much indeed. So I'm going to got about 20 minutes or so to talk to you about vascular rings and the ultrasound appearances and implications. I'm going to try and focus down a bit because I think if we try and cover everything, it's going to get too much. So I'm going to try and cover some of the main things. Those are my disclosures. And so why is there an interest in this? I think the interest in vascular rings has really stemmed from the fact that we now include more views such as three vessel trachea views in our normal screening views. And this has really led to a very big increase in the number of prenatal cases identified, and particularly variations in the aortic arch. A major part of what I'm going to talk about is going to relate to the right aortic arch or double aortic arch. And there's a lot of controversy, as you might expect, about how to manage these things. I'll talk a bit about that. So if we look at things, this is from Joanna Miranda's data right back to 2014, where you can actually see that when some of the new guidance came in around 2010, 2011, even at that point, we were seeing a big increase in the number of cases with right aortic arch, with congenital heart disease and isolated right aortic arch being detected. So these are some of the core images which I think we need to have in our minds when we look at the fetal scans. We tend to cut in cross-section, but if we look at the whole anatomy here, you can see on the image on the left where you have a left-sided aortic arch and left-sided arterial duct. And the key point here really is that the trachea and esophagus are right side, they're outside of the action, if you like. The aorta passes to the left of the trachea. You can see the innominate artery arising and stays on the same side on the right, left carotid, left subclavian, and the usual position of the left-sided arterial duct. However, you can have a situation where the aortic arch passes to the right of the trachea. So in that situation, the usual pattern is that you can have a couple of variations. First of all, because the right aortic arch passes to the right and the arterial duct is on the left, the trachea and esophagus are now between the aortic arch and the ductal arch. In some of these fetuses, there will be mirror image arrangement of the arch vessels. So there would be an innominate artery crossing the midline, giving rise to a left carotid and left subclavian. But in the example I've shown here, which we'll see later, is a very frequent variant where there's a later rising aberrant left subclavian artery. So it arises really very posteriorly here, and the left carotid is actually rising separately. So right arch, left duct with an aberrant left subclavian artery. And then we look at probably one of the simplest forms of double aortic arch, where we see the aortic arch, an aortic arch passing to the right, which is usually the dominant aortic arch, and the aortic arch passing to the left, and a more symmetrical arrangement of the great arteries. In addition, there will also be the usual ductal arch. So essentially on the upper mediastinal views, you'll see 3 arches, and we'll see some pictures here. If you look at the why are we interested in all of this? We're interested because there is, if the trachea and esophagus lie between either between the arches or between a right arch and a left duct, there is the potential for compression of the trachea and bronchi and the esophagus. And you can see in terms of the actual surgeries for compressive right aortic arch or double aortic arch, that this is increased really in line with the recognition of this pattern prenatally. And this pattern seen both at our own center, it's also a similar sort of patterns being seen at Great Ormond Street, where they have one of the national tracheal services in the UK. If we look at the incidence, our own group looked recently at 33,000 pregnancies. Now, this is a population-based study from South London and found an incidence of about 5 per 10,000 of isolated right aortic arch. I'm now talking about fetuses without other cardiac abnormalities, and 1.5 per 10,000 of double aortic arch. And in those with an isolated right aortic arch, there was a 5% incidence of chromosome 22q11 deletions. Now, this is not the only genetic abnormality that's seen with this type of pattern, but in most people's series, it's the most frequent. So if we look at how we translate this view into what we look at generally on our fetal echoes and the upper mediastinal views, you can see here, as we look into the 3-vessel trachea view, we actually see a cross-section of the superior vena cava to the right here, left side of the aortic arch and left side arterial duct. I haven't shown the trachea in this image, but it would be over to the right here. So outside of this V formed between these 2 vessels. And if we look at this in terms of the moving images, we can now see the 3-vessel trachea view. You can see the pump starting from the left here, the right ventricle, pulmonary valve, main pulmonary artery and duct, transverse aortic arch here, SVC over to the right, and the trachea is outside of this V, so it's really not part of this whole setup at all. And this is labeled image for reference on the left. If we look at the right aortic arch with the left arterial duct, then this really looks quite different. And you can see here in this example that you lose, now you can almost see the kind of vessels coming around in a U shape at the back. So there's first of all, it's rather than the V, you often get a kind of U shape here at the back. You can see if we start maybe on the left here, as this did last time, this is a pulmonary artery leading into the duct, which is to the left, as we'd expect. But the right aortic arch has a more AP orientation. And rather than crossing over to the left of the trachea, the aortic arch is to the right of the trachea here. So a right arch, left arterial duct, and the trachea and these structures here are now between the vessels rather than outside the vessels. If we look at this in terms of using our color flow Doppler, you will see the right arch, the left duct, and you will also see on the moving image a late arising aberrant left subclavian artery. So here we see the SVC, right aortic arch, left pulmonary artery and arterial duct, and the late arising aberrant left subclavian artery here. But what you will see when you look at these cases is that, and this causes sometimes some diagnostic confusion with a double aortic arch, is that you will see the right arch here, but as we showed from the earlier diagrams, the left carotid has to cross the midline, and this passes across the midline and up towards the head on the left side. So you will see, if you like, a vessel arising from the right aortic arch, both anterior to the trachea, as well as the late arising aberrant left subclavian. And here you see the left-sided duct with the same implications about the trachea line between these great arteries. If we switch now to look at the double aortic arch, usually the right aortic arch is dominant, but not invariably. And you can see these actually encircle both the trachea and the esophagus. And usually there's a more symmetrical appearance of the head and neck vessels. So when we look at this on the grayscale, you can see there's a SVC here, a right-sided aortic arch, a smaller left-sided aortic arch, and a left-sided arterial duct. And one of the important points here is that you can see that the anatomy of this left aortic arch is really quite variable about where it inserts, about whether it goes very posterior or whether it's more inserting into the left-sided duct, which is something we'll discuss a little bit later on. And when you look at this, this is differently orientated here, but now what you can see is a right aortic arch, a left aortic arch, and left-sided duct. And you can see this kind of Z, like a Z sign, or Z if you're in America, sign from the right arch, left duct, which you can see in here. And you get, as you see this sweep, this kind of more U shape of the right arch and left duct coming in behind the trachea and bronchi here. So, so double aortic arch. And very important in these cases. Sometimes this is very obvious early in gestation, but this can become a lot more obvious in later gestation. So quite important to follow these cases up. Now, one of the things which we've looked at a lot, and I'll just stop this for a second, is the use of fetal cardiac MRI. I think you're going to be hearing more about this later in the series, but what you're seeing here, this looks like a sort of unmoving MRI image. But the trick of this, and I'd refer you to the paper in the Lancet from a couple of years ago, is that this data set, one of the problems with MRI is actually accommodating fetal motion. And what this data is made up of is multiple MRI slices, which are then all reconstructed and importantly, motion corrected by computer, so that what you get in the end is a unifying three-dimensional data set, which you can walk through in the same way as you do with MRI, which we're used to seeing postnatally. So you'll actually start to see some more familiar structures as you kind of come through here, looking through the aortic and ductal arches here. See the arch structures here, you can align to them. This is where it's now being segmented. This gets done automatically. And now when you subtract the outside image, you now get into seeing the internal anatomy of the vessels. And this gives us like a cast of the vessels around the, it's particularly good for the non-moving structures like the vessels and veins, arteries and veins. We're working on things like how the ventricle's in motion, but particularly strong on these at the moment. So if you look at something here, for example, this is the 3D motion corrected MRI with the right arch, left side arterial duct, and putting the trachea back into the shot. And what this really does give us is a really, I would say, unrivaled ability to visualize the anatomy of the aortic arch. And very importantly, it gives us insights to the transition between the prenatal findings where ductal structures are present, like the arterial duct, versus when the duct closes after birth, so following closure of the arterial duct. And this is a really some very important points here. This is from Milou van Poppel and our MRI group on the paper from 2020. And this is a really important sequential slide. These are from the same patient. So if you look at this, you'll see there's a right aortic arch here. This is on the MRI, a left aortic arch. And as I mentioned, you can see that the left aortic arch is actually inserting into the arterial duct. And if you look at this from the sagittal view, you can see this left aortic arch inserting into the arterial duct. So when postnatally, when you look at the postnatal CT, as the arterial duct closes, there is, if you like, acquired atresia of the left aortic arch here. And again, I think if you looked at this postnatally, you'd probably say this looked more like a right arch with mirror image and the Comerle's diverticulum you see here from the descending aorta. So what we get is some really helpful insights into how the anatomy is prenatally and how it then, what that translates into postnatally. Remembering that all of these contrast enhanced techniques postnatally can only detect patent structures. So if the duct closes and the vessel closes off because of ductal closure, then we don't see it on the postnatal imaging, although we might see it at surgery. The other finding here, important thing here, which is if we look at the switch a little bit now to how we manage some of the cases of looking at the patients with right aortic arch and left duct. So I'm moving now to like how do we manage these cases? From some of our earliest data, this is from 2018. I think traditionally we've said, look at the symptoms like noisy breathing, recurrent infections, or whatever, then we'll look to investigate. And we got caught out with a couple of cases of babies who ostensibly had no symptoms, but when they did have a bronchoscopy for other reasons, and a couple of these babies initially came up because they were coming for anesthesia for other indications, then you saw in some of the asymptomatic patients, so these are all infants, tracheal compression. And I think when I look at some, I'll show you some further slides, I think this is significant tracheal compression in anyone's book. And we've used fairly standard definitions of what that accounts for. And the sort of procedure we used here really is a free breathing bronchoscopy and CT scan. So we're seeing the patients as they spontaneously breathe rather than stenting the airways open with positive pressure. But the really important part here is that there is compression both in the asymptomatic group and in the symptomatic group. And this causes a real management dilemma. And if you express this differently, if you look at the proportion of patients having more than 70% luminal compression divided according to symptoms, you can actually see, although there may be slightly higher in terms of the proportion of the tracheal compression in the symptomatic patients, you know, there's a very big representation of patients without obvious symptoms in the asymptomatic group. Now, current approach for these patients is that when these are recognized, first of all, it's not that uncommon for us to recognize these. It's extremely uncommon for the baby to be in trouble with symptomatic compression around the time of delivery. But we do take, these babies deliver locally, but we do take the advise that there's a pediatrician present at delivery in case of early significant compression. In our own series, our latest data, the incidence of clinically apparent compression at delivery is only about 5 to 6%. If the baby is, we follow them up. If the baby is symptomatic, then we do offer early investigation with CT and bronchoscopy. If they're asymptomatic, we tend to keep them under review And then depending on, we have a discussion with the parents about whether we just simply keep them under a bit further review or whether we actually investigate them with CT and bronchoscopy. And the results of those things really are discussed in MDT. So this involves respiratory pediatricians, ENT, bronchoscopists. It's by no means a cardiac decision, as well as obviously cardiac surgeons who do the actual surgery. Now, when we look at the double aortic arch, this is a very, very busy slide, and apologies for that. But what I want you to note from this, from the double aortic arch, is when we look at these in terms of, this is a very recent paper when we're looking at comparing the prenatal and postnatal data. When we look at these cases, we can see that the true complete double aortic arch is actually the minority of those that we identify with a double aortic arch before birth. Most of them acquire atresia following arterial duct closure, either between the left carotid and left subclavian or distal to the left subclavian after birth. And we know that from the prenatal MRIs. You can see that there is an incidence of abnormal genetics, but not some of the things perhaps you might expect. You can see that at some point, most patients, but by no means all, develop symptoms, that probably only around 1 in 5 overall have got symptoms within the first 24 hours. And if you look at those in terms of the bronchoscopy findings here, in terms of whether they have, you do have some normal bronchoscopy, so in about 1/5 of cases, is it maybe 10 to 15% of cases overall, milder in another group, but really quite an incidence of moderate to severe compression. A minority have got GI symptoms. So these patients, again, just to look at this is just another example of the prenatal versus postnatal findings. Right arch, left duct here, and you can see here the acquired atresia postnatally between the left subclavian, after the left subclavian here in the smaller left-sided aortic arch following ductal closure. And you can imagine where the duct is in this type of arrangement here. And occasionally, as I've said, but in the minority, you can also see atresia develop between the left carotid and left subclavian here. This is on the postnatal imaging, but that's the minority rather than majority. Most of the acquired atresia is beyond the left subclavian artery. If we look at the onset of symptoms here, now, when we look at this is from, again, very recent data. If you look at the age, if you look at ventilated patients with stride or noisy breathing, this is the age at onset of all of these type of symptoms. If you look at the asymptomatic patients, this is, if you like, this is their age at the last follow-up. And if you look at, this is, again, let's say in the double aortic arch group, the freedom from symptoms really goes down. So probably about 20% are free of symptoms beyond a year of age. And although it might vary slightly by the precise anatomy, the trend is the same for all of these groups. So our current approach for these patients with double aortic arch is clearly, if they're symptomatic, they go for CT and bronchoscopy. And we tend to investigate these patients given the natural history that we see early at around 2 to 3 months. There's an MDT discussion and then a case by case. And our respiratory team have developed a kind of symptom-based questionnaire so that there's a sort of structured review of these patients rather than a sort of ad hoc type of review as to what the symptoms the patients actually have. I'm going to talk very briefly. This is some data which is submitted but not published, is that look at the surgical procedures here. If we're talking about the either right aortic arch with left duct or double aortic arch, clearly the vast majority are done by a left thoracotomy, dividing the ductal ligament. The commons diverticulum, so that outpouching we're seeing on the descending aorta, is either suspended posteriorly or excised. Double aortic arch, usually the left aortic arch is divided in the vast majority the ductal ligament is also divided. And similarly, the aortic diverticulum is either excised or suspended posteriorly. We've not had any deaths, but we don't take this type of surgery lightly. You can see about 9% of patients have vocal cord palsy, 1 in 25 with chylothorax, pneumothorax. Rarer and other wound-related problems may also occur. And if you look at this in terms of, this is again is submitted data, if you look at persistent symptoms according to the type of vascular ring, is even when you have treated these patients, we do need to, they do need to get some sort of follow-up in terms of, although their symptoms tend to become less with the passage of time following early relief, there's certainly, it's not the case that just by operating that there's always immediate relief of symptoms. This may take more time. So I'm going to stop there. I'd like to thank, there's a big team involved in whether it's MRI scans, fetal cardiologists, and those involved in all aspects of management that I've listed here. I thank them for their input to these patients. Thank you very much indeed.
Thank you so much, Joan. As usual, very informative, up to date, lots of publications and literature. Dr. Silverman, do you have any comments? Dr. Silverman? Okay.
Sorry, I'm sorry. I'm back. I'm sorry. I forgot to unmute myself.
No problem.
I would like to congratulate the group at Evelina on their spectacular foray into this whole issue of vascular rings. And I think that this has been a beautiful presentation. The one thing that strikes me about this, John, is looking at this as an old pediatric cardiologist from the point of view of the diverticulum of Comeril. I mean, I think that what you showed perhaps is that many of these diverticulums of Comeril were really, in essence, at the beginning, double aortic arches. Is that correct?
I think that's a really interesting point as to what it actually is. And it may well be that a lot of the, certainly where you look at those who acquire the atresia, you frequently see that, but you can also obviously see it in those where we now are very sure that they never had a left-sided aortic arch. So you could say, is it the distal part with acquired atresia? But you certainly see them, as we showed on some of the images, on that in patients who we are very confident that they never had a left-sided aortic arch. So I think that appearance, I'm almost, you know, I guess that's what we call it. But I think it's something in terms of my interest in that is I think most of the surgeons, and there's a really nice review very recently by Carl Bacher about this exact subject from prenatal diagnosis, is the significance of doing something about that Comerils at the time that you deal with the vascular ring in terms of the longer term. And that's certainly been our practice. But I think you're exactly right. There's a real issue about what we call this and what the definition is.
Sure. The interesting issue is I have never read the paper by Comeril, which is written in German in the mid 18th century. But what he said, from what I understand from the interpretation, is that that when you get the diverticulum, that there is also a strand of tissue that makes a vascular ring. And I think we use this term quite loosely in terms of what we say a diverticulum of Comeril is, but that's what Comeril originally described as the abnormality. So there was, in his mind, and from his dissections, also a remnant of another aortic arch.
I think that's being frequently discovered at surgery, and you can see that from that case I showed where you'd said, if you only looked at the postnatal imaging, you'd say this looks like a right arch or mirror image. But when the surgeons get in there, they may find a ductal ligament, but also find what may be a distal aortic arch ligament, which of course, unless you imaged whilst the fetal shunts were present, then you may not necessarily you may not necessarily see. And certainly in my own practice, one of the reasons you might say, well, if you can get the fancy MRI pictures, but why do you really need that? I think it is extremely helpful to know exactly where vessels are fit when you've had the fetal physiology, and then look at what you're seeing afterwards, because I think we're probably only at the early stages of understanding a lot about that transition. There's a couple of surgical series or papers being prepared from our group. I've shown you a bit of what's been submitted, but I think the pictures of what the surgeons actually see will be, it's very interesting. I have got some, but I've not had time to show them.
Well, the other thing that comes out of your series, John, is the fact that when you have a double aortic arch, the amount of symptomatic problems, including the issues in the tracheobronchial tree, are really quite significant.
I think that's true, and I think particularly acute in the double aortic arch group. It does look like they become more symptomatic earlier. The interesting thing about symptoms, and I don't profess an expertise here, but when you talk to the respiratory pediatricians, is that in infancy we're breathing very fast with a very shallow. We breathe fast and shallow, fast with a small tidal volume. So you can actually accommodate quite a lot of compression compared to what happens as you get older. Certainly taking a more structured, involving other specialties in terms of assessing symptoms has been helpful to us. As I've emphasized, this is the decision to operate is the decision to operate is taken within the whole kind of a much wider group than simply the cardiologists.
John, there is a question here saying about, do you have data about the timing of surgery for vascular rings?
Yeah. Well, there's a spread. I think when you saw I should have perhaps left it up for the vascular rings. Most of the double aortic arch now are being done within the first 6 months or so. There are 2 peaks of the right arch, left arch. Clearly, the patients who are symptomatic, we investigate as they become symptomatic. If they don't become symptomatic during the first year, we do have a discussion with them about to what extent we investigate them. And that varies about, there may be some, if the child is asymptomatic, quite a lot, understandably, about reluctance to push investigations when there's a lack of symptoms. So there's another peak, probably between about a year and 18 months. On talking to our surgeons and again, from not just our surgeons, but some others, and saying, when would they prefer to do the operation? I think most of the surgeons that we've spoken to, and there was a meeting about this in Utrecht last year, 2 years ago, which was addressing this. Most of the surgeons said they would definitely prefer to do this in a child who's, say, before the age of 3, preschool for sure, rather than dealing with this in a much older child. So there looked to be a preference, if they were to do something, want to do it earlier. And from the respiratory pediatricians, their view, consensus, both internally and from some of the meetings, has been that if you are going to relieve this, you should do it early, because if you're going to promote normal tracheobronchial development, the best time to do that is in the first few years. There's a lot of cases in terms of particularly older patients, but you see some persisting symptoms even in our younger patients that, the trachea may be floppy, there may be true underlying malacia, and that needs to also recover as the child grows. And their feeling is that they would sooner relieve this earlier to promote the best chance of airway development.
When does the atresia happens in utero, where the two arches become, one of them disappears?
I don't think this happens in utero. I think this is a postnatal phenomenon. I think this is something that, now the vast majority of our patients, strictly speaking, we say we've only done 1 MRI, we've not done 2. But when you look at the patients, the MRIs we tend to do past 30 weeks currently, because that's when the best resolution of the MRI is. They prefer the later gestation. But I think that the acquisition of atresia is a feature of ductal closure, because as you look at these more and particularly in the prenatal MRIs, the left arch is essentially more inserting into the arterial duct. So it's probably not surprising that as the duct constricts, that you effectively are acquiring atresia there. And there can be a bit of a moot point about where the left arch ends or is and where the duct is, and what you call the tube between that they, if you like, share before birth. But certainly as the duct closes, that's when the atresia occurs, usually distal to the left subclavian.
Yeah. So it's a duct dependent phenomenon, more or less. Delaney, do you have any comments? Are you still there?
Yes, of course I'm here, Iman.
Okay.
I was about to say something. I think it's all very interesting data, particularly, adding the MRI and everything else. But I think we also have to think about, we are diagnosing a huge number of right aortic arch, and less so of double aortic arch, but more than we used to before the 3-vessel trachea view was introduced. So the incidence of right aortic arch hasn't suddenly increased. What happens is we are picking up not a small number, quite a large number of babies. We probably see 1 or 2 a month, sometimes more. So that amounts to a large number of babies. Only a minority of those become symptomatic. Mm-hmm. So we just need to be careful not to jump into over-investigating and over-treating babies. That if we could look back at the whole general population, there are loads of children, adults out there who have a right aortic arch, who never had the problem, probably never will have. So I think, we have to find a balance. We have, before doing too much, I think we need to find what is actually important in terms of indication for surgery, because some groups would advocate even to implant the left subclavian arch in all cases, which may, is not without consequences. So I think we just need to put things a little bit in perspective as to why we shouldn't suddenly be operating on a huge number more than we used to, probably a little bit more, but not a lot more.
Do you believe in doing like a chromosomal screening or NIPT for arch anomalies? Because I haven't heard Joan saying anything in the study that it was included. Probably there is a reason for that, or there's no reason for that.
Are you asking me, or I
yes.
would? Yeah, absolutely. We would have a discussion about it, and I think if the data on incidence is quite depending on whose series you read, then there is quite a large variation in what people describe as the incidence of associated genetic abnormalities. And depending on series, you can go anywhere from 0 to up to 15-20%, depending on where you include babies with lots and lots of other things. I think the most, if you look at our population series with a right aortic arch, the incidence of 22q is about 5%. But I know that different fetal cardiologists, we do bring it into our discussion. I think different fetal cardiologists use different numbers. If currently, if we see something around this with a fetus who does not have major other markers, I would probably be looking at a figure of around 5%, basically which is from our population type data. Others might disagree with that, but that's what we would do. NIPT you mentioned, but the testing for 22q on NIPT is far from perfect, and so that again is a again, it's an individualized discussion with the parents about what they would want to know. We would routinely do it after the baby's born if we haven't done it beforehand, but that's a discussion, but it is discussed in each of these cases. And I haven't majored on that. I think it's another talk about strength of association.
Thank you so much.
I would agree with that.
One quick question. After birth, do you use CT or MRI or both? What is your preference? Quickly.
Currently, it's CT generally in the smaller patients because the dose from CT has come down so much. It's really fast. And some of the CTs now are if you take some of the, say, a small baby and you want a CT for this type of information, the CT dose is equivalent to about 3, maybe 4 chest x-rays. So the doses come right down and it's super fast. So that's our preference. I think if you're serially assessing someone, then it would be then MRI, of course, comes into it. And there's different units debate the use of bronchoscopy, and there's a lot of fancy ways of imaging the airways on CT and other imaging. Currently, we still do, but some people don't.
And it's CT with contrast, I assume.
I think so, yeah.
Yes.
Okay, good.
And probably this is what they call flash CT or whatever. It takes only 2 minutes to acquire, or 3 minutes. Right. Delaney, you wanted to comment before we move?
I was just going to comment on the chromosomes. I think if you do diagnose antenatal right aortic arch, you do have to inform the families there is an increase in risk of chromosomal exocardiac abnormality, genetic syndromes above the background risk for every pregnancy. I don't think that risk is very high. If you exclude other things from the scan, I think I would use a similar number to John. If the nucleotranslucency was normal, there's no exocardiac abnormality, I think the risk is no more than 5%, but it is increased compared to the background risk. So at the end of the day, it depends on how each family takes that information. If it's a very precious baby, they don't want to take a risk of, they might accept the risk of the baby may have trisomy 21 or DiGeorge syndrome, or against a 95% chance that a baby is not going to have that, as opposed to risking the pregnancy. So at the end of the day, it's an individual family decision, but having to raise the issue with them, I think we ought to, because there is a slight increase in the risk compared to the background risk.
Would you offer an NIPT or a modified NIPT? Because I know that they're working on the 22q and the NIPT. Would you at least mention it, or you would not offer it at all?
I think we would, if there is an abnormality, our group tends to, the obstetrician, we mention it, but then they are seen by the obstetrician. Amnio, obviously, or the caudal is usually an amnio, it would be the preferred one, because you're not just trying to exclude trisomy 21 and 22q, and the families that want an invasive test, they go for that. If they don't want, and then they have the option of an IPT, but again, with the limitations, particularly for 22q.
Thank you so much. I think we have to move our next speaker, last but not least, the very famous, well-known Professor Gerline Charland. Professor Charland is an NHS consultant in fetal cardiology at Evelina Hospital. She is regarded as the leading expert in fetal cardiology, both nationally and internationally. Until recently, she was the president of the Association of European Pediatric and Congenital Cardiology, the AEPC. She's a professor of cardiology, invited members, lots of publications, peer-reviewed journals, and she has also lots of people that she helped a lot to establish their career in fetal cardiology. Welcome, Professor Charland.
Thank you very much, Rima, and thank you also to Norman. My talk is slightly different. Delaney and John have both given excellent presentations to show you how well and in how much detail we can assess things in the fetal heart. But I'm actually going to take a slightly different approach and show you where some of our weaknesses are in terms of, even in experienced hands, some of the difficulties we have with certain diagnoses. I don't have any disclosures for this talk, So the diagnosis of congenital heart disease before birth is well established, and many experience centres have reported a very high degree of diagnostic accuracy, even in early gestation. And you've heard already in this session some of the things regarding that. So we can confirm normal heart anatomy, we can diagnose congenital heart disease, we can diagnose arrhythmias, we can detect abnormalities of function, and we can identify cardiac markers of other abnormality. But is it really always so easy? And where are the pitfalls in diagnosis? Or do we always get it right? So I'm just going to break this down in various subheadings. So first of all, one can think, is it actually a problem or not? So even experienced people are faced with certain scans and you think, well, is this a problem or is it not a problem? And the classical main example of this is coarctation of the aorta. We published a paper way back in 1994 talking about the difficulties in prenatal diagnosis of coarctation. I have to say, although things have got better, we still have some of those difficulties. One of the reasons is that many of the postnatal features one might see are not seen in the fetus due to ductal patency. So, for example, we would not see gradients across the coarctation shelf. And we are therefore making a diagnosis or suspecting a diagnosis based on indirect signs. In the early days, we gave a lot of focus to the right ventricle being bigger than the left ventricle, so the four-chamber view being asymmetrical. However, we've learnt in more later years, if you like, that actually it's the great artery disproportion that is much more important in this diagnosis, and in particular, hyperplasia of the aorta and the isthmus area. And you can assess this in 3 vessel tracheal views, and you can assess this in longitudinal views of the aortic arch. So just to show you, here is an example from a baby that had a coarctation. So we're looking at the 4-chamber view. This is left, this is right. And you can see that the right side of the heart here looks dilated compared to the left. The actual connections of the heart in this baby were normal. And then we come up to look at the 3 vessel tracheal view here. So this is the pulmonary valve, main pulmonary artery going, and this is going down to the duct. And this is the aortic arch going down towards the isthmus. And you can see that there is hyperplasia here. And this type of appearance makes one very suspicious that there might be a coarctation. And if you can actually get a sagittal view of the arch, that might help you. So this is the true aortic arch here, distinguished from the ductal arch. And you can see the aortic arch looks hyperplastic, and the 3rd head and neck vessel is displaced. So if you get this type of appearance in your scan, then you'll be having quite a high suspicion that there is going to be a coarctation. However, things are not always straightforward, and there's always grey areas. So I'm going to show you a couple of examples. So some of these are a little bit old, so please excuse some of the image quality. But here is a 4-chamber view again. This is left, this is right. The left side again here looks smaller than the right. The left ventricle is apex forming. And then when we come up to look at the 3 vessel tracheal view, here is the pulmonary artery and duct. This is the aortic arch here, and it's coming down towards the isthmus, and it looks a little bit hyperplastic. So in this example, we were suspicious that there might be a coarctation. It does fall into the grey area though, so it's possible it wouldn't be. But we were quite suspicious. And in this baby, after birth, there was no coarctation. Okay, so bear that example in mind, and we'll look at the next one. So here is another fetus. This is the left side, this is the right side. Again, the right side is a little bit dilated compared to the left side. I think the left ventricle here was reaching the apex. I think I've just foreshortened it in this view. And here is a view of the 3 vessels. So pulmonary artery here, aorta here. Sorry, I haven't been mentioning the superior vena cava, but the third vessel is the superior vena cava. So pulmonary artery and duct, this is the aorta. The aorta looks a little bit slender, but it didn't look too bad. And in this one, one thought, well, there might be, but probably it's going to be okay. And you can probably guess what I'm going to say here is actually this baby did have a coarctation confirmed after birth. Now, I haven't shown you the sagittal views in these babies. It's not always easy to get, but it is very helpful if you can get it. But one of the pitfalls with the sagittal view is it's really important, particularly if your images aren't very good or the baby's in a difficult position, to make sure that you are looking at the true aortic arch. There is overlap between the aortic and ductal arches, and this can sometimes lead to misinterpretation, particularly if the aortic arch is very small. So it's really important to try and get a good view of the aortic arch with the head and neck vessels before making a comment about whether the arch is okay or not. So you will see from this example here on the left, when we start the clip, you can almost be fooled that there is a good size aortic arch here. But actually, when you find the true aortic arch with head and neck vessels, it does look hypoplastic, and the third head and neck vessel is distally displaced. I hope you can all see that. And here is one similar to the first example I showed you, where this is not the aortic arch, this smaller one is the aortic arch, which is hypoplastic. And again, this example has a distally displaced third head and neck vessel. So if you can get this type of view, you can be more suspicious that there's going to be a problem. So I don't have an easy answer to tell you how you decide if it is or if it isn't. I think over the years, what has happened is that the false negative rate has gone down dramatically. So there's not many false negative diagnoses because of the way we're looking for coarctation, but the false positive rate still remains relatively high. And that's because we can't always be sure where in the grey area our scans are falling. Z-scores certainly can be helpful. My colleague Trisha Vigneswaran has published Z-scores on over 7,000 fetuses, and certainly we are using these in the department now to try and help us with our diagnosis. But having said that, it's not 100%. They don't 100% tell you this baby has coarctation and that one doesn't, but it does help us to fine-tune a little bit. And the other thing that we do in our unit, which you've already heard about from John, is we use fetal MRI. And fetal MRI we have been using to assess aortic arches in coarctation and other arch abnormalities. And we can sometimes get beautiful images that John was talking about, but my colleagues in the unit are also doing flow studies and looking at angles at which the aorta inserts into the duct. And this is work in progress to see whether we can fine tune things even further. Right, I'm going to go away from coarctation now. Another problem that often makes us sit there and think, is it or isn't it? And Rima specifically asked me to just mention ventricular septal defects because she gets asked about it a lot. It can be very difficult. So I don't have, again, special tricks for telling you how to make sure it is or it isn't. This was a scan here on the left at 15 weeks of gestation. And you can see that in this area here, one could be very suspicious of a ventricular septal defect. And this is very common to get dropout in this region of the septum, particularly on some of the earlier scans. And it's very hard to decide if it is or it isn't. Now, obviously, important to get different views of the heart. If you can see it in different projections, then you might feel more confident that there is one. If you can see color flow across the VSD, you can be more confident, but you can't always get it depending on what your image quality is like and what gestation you're at. So one could be suspicious of a VSD here, But this is the same baby at 20 weeks, and the ventricular septum at this stage looked intact. We couldn't see a ventricular septal defect. And actually that's quite important regarding what you're going to say at 15 weeks to the family. If you're going to say definitely there's a ventricular septal defect, there'll be implications for chromosomal abnormalities should they have invasive testing. And I think a lot of thought is required, and perhaps we could have some discussion about this at the end. The other way around, sometimes we see a ventricular septal defect. It might be small or tiny, but we detect color flow and we think there is one. And in this particular example, there was no VSD on the postnatal scan. Jelani already mentioned in her talk that we don't specifically look for these small defects, but if we see it, then we can't ignore it. We're going to have to say something about it. And she also made the very good point that it is important that you've checked everything else and that there isn't anything else wrong with the heart. And this is one that did have a defect detected before birth and was confirmed after birth. So we can go in that direction too, fortunately. Here in this baby, this is the left ventricle. We're coming up to a view of the aorta, and this area here, just beneath the tricuspid valve, is looking very suspicious. And we were able to demonstrate flow across that defect, and this defect was confirmed after birth. Sometimes you have diagnosis, again, particularly on some of the earlier scans or difficult scans, where it can be difficult to distinguish one from the other. And an example of this would be, is it a common arterial trunk, or is this pulmonary atresia with a ventricular septal defect? And usually, you know, you can see well enough to tell, but we have situations where it can be difficult. And these two clips are just to show you why it could be difficult. So here we have a ventricular septal defect, the aorta is overriding, and there's a small pulmonary artery coming off just here. And you can see how you could misinterpret that that is coming from the main vessel there, so that it could be a trunk, but in fact this vessel is coming directed towards the right ventricle, and this was pulmonary atresia rather than a trunk. In contrast, in this example, which is in a similar projection, we're seeing the larger vessel here. Here is the valve, but this time this vessel is arising from that vessel just above the valve, and this was a common arterial trunk. But you could hopefully see that if your image quality isn't very good or you're not getting the views you want, it would be very hard to tell the difference. Color flow will help. In pulmonary atresia, you would have reverse flow in the pulmonary artery. In a trunk, you should get forward flow going into the pulmonary artery from the trunk. Sometimes we can make a diagnosis, but then can we get enough information for our counseling? Again, pulmonary atresia with an intact, pulmonary atresia with a ventricular septal defect would be an example here. So these clips are from a baby that had pulmonary atresia with a VSD. There was balanced ventricles and aortic override. And this clip is showing you confluent but hyperplastic branch pulmonary arteries. So native pulmonary arteries were present in this baby. And, you know, color flow helped us to see that there was a lot of collaterals. I've just shown one clip here, but we had several others showing the collateral vessels. And this baby actually also had an arterial duct. But we sometimes get into a situation where we can't see that, where we can't see the native pulmonary arteries very easily. Again, maybe related to gestation, maybe related to image quality. And you may not be able to see the collateral vessels either. So here is an example of 4-chamber view and aortic override. And in this baby, we were just not able to see the source of pulmonary blood flow on the first scan. We saw it later, but on the first scan, we just couldn't see it. And then that raises the dilemma about what do you say to the parents about what's going to happen. Pulmonary atresia with VSD is a spectrum of abnormality, and the outcomes vary significantly depending on the exact anatomy. So what do we do if we can't see enough to tell us the information we need for counselling the patients, and would we see better later? And as you've already heard, if you work at the Evelina, you can call a friend. And in this instance, our friend would be the MRI team, or more specifically, the fetal MRI team, who can look, and they are able to identify collateral vessels. It's one of the things the fetal MRI is very good for. And having got these images, we were able to go back, and we actually were able to find where the collateral vessels were. Then we have a situation where we know fetal diagnosis is not easy for the diagnosis. We've got better at it, but even when we know that we might miss it, we can still miss it. And classic example here is total anomalous pulmonary venous drainage. Fetal diagnosis has improved considerably in this diagnosis, but over the years, the detection of this abnormality before birth has been low. This is normal on the left here. So normal four-chamber view, and we can see pulmonary veins actually going in to the back of the left atrium. And you also see just on the 2D part of the clip that it looks like there's something going into the back there, and the distance between the descending aorta and the left atrium here is not very marked. This is just another clip where we see pulmonary veins going into the back of the left atrium. So we can actually see them draining into the back of the left atrium. In this example, the distance between the descending aorta and the left atrium is increased. The back of the left atrium looks a bit smooth walled. There doesn't seem to be anything going into it. And we can see a confluence here behind the left atrium. We can see the veins, pulmonary veins, draining into the confluence behind the left atrium, not actually going into the atrium as in the normal examples here. When we come up to look at the three vessel tracheal view, this is pulmonary artery, this is aorta, superior vena cava, and superior vena cava here looks a little bit dilated, and there seems to be an extra vessel lurking in here. And this was an ascending vein that was coming up to drain into the superior vena cava. For less experienced people, it is important that when you are assessing the fetal heart and making a diagnosis of a problem, that you're actually in the right plane for looking at whatever structure you're looking at. And I'm just going to show you an example. So this baby was referred as they were worried that the baby had an atrioventricular septal defect. Because there was no differential insertion. And you can see in this clip why they would have thought that. We can't see differential insertion. This is the right side here and the left side here. But what we're looking at here is a dilated coronary sinus. And the plane that we're looking at isn't the correct one for assessing the AV valves. And you can get this view and mistake it for being no differential insertion and an AVSD. But in fact, when we get onto the correct plane in this baby, here's the dilated coronary sinus, balanced ventricles, and the atrioventricular septum appears intact. So here's primary mitral septum, here's the ventricular septal defect, and there was differential insertion of the valves. So important to be in the right plane. Many times we make a diagnosis where it looks like something at 20 weeks, but we have to think about, will it get worse? Will it not get worse? Obstructive lesions, obviously a classic example of this, where they can get worse and progress, but also functional lesions. So will the function of the heart get worse? So this lady presented at 24 weeks. She was almost impossible to scan. She was rather large. And what we were seeing, the actual connections of the heart were normal, but the right side here, we thought the right ventricle wasn't contracting very well. It just didn't look quite right. And there was tricuspid regurgitation at this stage. We didn't know why the function was impaired. She had various investigations done, but we didn't actually establish the cause. And then a scan at 29 weeks, the baby has developed ascites. There's now quite marked cardiomegaly, poor biventricular function now, so both sides of the heart don't look great. And there was quite significant tricuspid regurgitation, and there was also mitral regurgitation. So over 5 weeks, the function here has deteriorated quite a lot. And, you know, when faced with scans at 20, 22, 24 weeks, trying to predict what's going to happen isn't always easy. Other sources of grief sometimes in decision making is trying to decide if urgent treatment is going to be required after birth and alerting relevant teams that something urgent might be required. A good example would be simple transposition of the great arteries, where you've made the diagnosis of simple transposition, but we have to assess the atrial septum, particularly in later pregnancy, to see if it shows potential for restriction. Will an urgent septostomy be required? So this baby had transposition. I haven't actually shown you the transposition in the scans because I was focusing here on the atrial septum and the foramen ovale. At 20 weeks, the foramen looks pretty widely patent and we weren't really concerned about it. But just to show you how important it is to perform scans later at 35 weeks now, this is the atrial septum and it looks much, much more restricted. It hasn't narrowed down completely. There is a way through, but it is a restricted septum. And this baby did have a septostomy at a few hours of age because that did narrow down further. We, in our department, have looked at factors that might help us to decide if the atrial septum is going to be restricted. And one of the things we have found helpful is measuring the foramen ovale size and comparing it to the total septal length. And if it's less than 0.5, we would raise suspicion about there might be a problem. The other thing that sometimes happens is we can make a diagnosis, but what about predicting associated lesions after birth? So the diagnosis might be correct, but in our counseling, how can we be sure about what else might happen? So I've used example of atrioventricular septal defect with left atrial isomerism or heterotaxy. So here we're seeing a complete, we're seeing an atrioventricular septal defect in this baby. We can see an azygous continuation here behind the descending aorta, which we can also see in this view. So here's the descending aorta, and here's the azygous continuation coming back to the heart. So we've made the diagnosis of an atrioventricular septal defect and isomerism, but what about development of heart block? What about malrotation? And what about development of biliary atresia in rare cases? Obviously, this will impact on the outcome, but trying to put all of that into your counselling can sometimes prove challenging. Can we always predict outcome? We think we know a lot, and we do know a lot, but we all get caught out, even experienced people. So here is an example of a baby that had tricuspid valve dysplasia. So the tricuspid valve here looks dysplastic, the right atrium is huge, the whole heart is huge. And here is tricuspid regurgitation. So this baby had sort of a wall-to-wall heart, severe tricuspid regurgitation, and the pulmonary valve was actually patent. There was pulmonary regurgitation, but no forward flow. So this baby has functional pulmonary atresia. I'm not sure what everybody else would have said, but at this stage, we gave this a very poor prognosis and said that it was unlikely this baby was going to survive the neonatal period based on previous experience. But we can be wrong. This is an echo from the same child at 37 months of age. The child is actually a lot older now and is still doing okay. Tricuspid valve is not quite normal, but it's not doesn't look as bad as it did. Tricuspid regurgitation is still there, but again, it doesn't look quite as bad as it did on the prenatal scan. And the heart size has improved significantly. And here we have good forward flow in the pulmonary artery, a bit of pulmonary regurgitation, but good forward flow in the pulmonary artery. So we can be surprised sometimes. I've put this in to say that every now and then you see something that you've never seen before and you don't know what you're going to say to the parents. And this was, I've put this in because the first time I saw something like this, I really wasn't sure what it was. And obviously with time you learn and you know what it is, but for people who haven't seen so many. So when we saw this, it looked like it was actually part of the right atrium. But in fact, this is a teratoma sitting on top of the heart. And at the time, it looked very scary, and a sort of poor prognosis was given. But in fact, this was removed after birth, and the baby has had a very good outcome. So, you know, again, it might be good to ring a friend if you haven't seen something before. At that time, I didn't have a friend to ring, sadly. And this is the last example I'm going to show you. Is your first impression always correct? Are you paying enough attention, or are you doing something in a hurry and jumping to conclusions because you think it's something based on what you've quickly looked at? So in this example, what we're seeing is two equal-sized ventricles. Here's a ventricular septal defect. And there was a vessel here overriding that defect. We can see the valve here. And that was a bigger vessel, and then there was a smaller vessel here, okay? And the smaller vessel is coming anteriorly from the right ventricle. So initial impression here was that this baby has tetralogy of Fallot. And if you look at that quickly, you will say, yeah, it's got tetralogy of Fallot. But if you look more carefully, the bigger vessel here actually was a branching vessel. And the smaller vessel was the more superior vessel. So you have to come up quite high to see it. So this was actually the aorta. And this baby actually has transposition of the great arteries and had a VSD and a coarctation. So the message there is look carefully, go through it systematically, don't jump to conclusions, just be sure of what you're seeing. And sometimes just describing everything you're seeing first helps to get to the final diagnosis. Thank you very much for your attention.
Thank you so much, Professor Garland. And I think it's a beautiful talk. The question here for everyone now, and on this, what about the VSD, please? I think this is very important, Joan and Jelani and Dr. Silverman and Dr. Awad. Now, what you see, the dropout, it's very amazing that you did not use color in the detection of VSDs most of the time. And I wonder how one could be very sure that, I mean, you get a referral that, is this a possible small VSD? And then we send a referral back, say, possible small VSD. I mean, it's a bit, how could we be sure, especially our maternal fetal medicine colleagues who are trained, some of them are trained to do fetal hearts. Can every one of our panelists talk about the detection of small VSD, premembranous VSDs, and how confident we are in this? Professor Charlin, and then we go to Joan and Carvalho, Professor Carvalho and Professor Silverman.
Well, I would like to say that I don't really care about small VSDs. That's the first thing, because it's a small defect. There is an ongoing natural history of closure of VSDs. There's nothing remarkable about birth as far as the VSD is concerned in its natural history. The other question, of course, is when you say color can be a real negative for diagnosis, because you can see bleeding of color across a ventricular septal defect or across a ventricular septum and believe it's a ventricular septal defect. And certainly, I think the issue with almost all VSDs, a statement made many, many years ago by Dr. Rudolph, is all ventricular septal defects tend to close. And so I think that when you find a small VSD, that you really need to just look at it over the period of time, and maybe this period of time includes following the patient after birth. And I think that's a small issue. I think the most important message from your paper, Gerline, and I respect your vast experience, is that for the people that are looking at this webinar from a perspective of less experience than you and I have, perhaps, is that if we can make mistakes, and we do, then always beware yourself that when you look at this, that you can make mistakes. And I think you've shown us some beautiful examples. The coarctation story is really maybe MRI is the way, because there are so many papers now, including some that I've written, that say, oh, well, you can make the diagnosis if you measure the subclavian artery. And some, oh, whether you get the Z-scores of the aortic arch and so on and so forth. Or whether you look at ventricular disproportion, which you've done so clearly. And I mean, I think that this is an ongoing strategy. And my colleague, Dr. Wayne Turetsky, has always said that the suspicion of coarctation is a win-win situation, because you win if you've diagnosed a coarc and the patient has a coarc after birth, okay? And the parents win if you made the wrong diagnosis and there's no coarctation. So I agree that that's a win-win situation, and clearly it's something that you have to follow. The other issues that you have, I think, are really sobering experiences. I think total veins, for example, again, talking about what Jelani had said earlier on, was that color is really your survivor in the diagnosis of total veins.
Yeah.
And I think that we have, for some reason, a lot of referrals of patients with pulmonary atresia MAPCAs to our situation. And I think there again, the accurate look at the Doppler color is very helpful in terms of making the diagnosis. And it's a very complicated situation, and nobody has a clean slate in terms of their positive diagnosis in this condition. So overall, I think my feeling is it was wonderful to listen to three vastly different experiences and styles from the three presenters this morning, and that the information that I've gathered, certainly, and I hope for the rest of the audience, has been really quite remarkable. And I only want to thank you all for what you've said today.
Thank you so much. Joan, what do you think of the VSD? The story that I know the small VSD, the small muscular VSDs are not that important, but we're talking about you are in the lab and you are faced with a VSD at the perimembranous near the valves and so on. What would you do to make sure that you're not missing? I know that you're very meticulous. Would you go by color? Would you go by 2D? Would you just say, as Dr. Silverman, it's not important?
I share Norman's view that if you're talking about a small VSD, even if you're talking about perimembranous or muscular, if you look at things purely through the eyes of the cardiologist, you would say, so what? Even if it needs closed in a good center, you should get a good result, and it may well close on its own. So what? I think the catch on all of this is the associations. And the time that I've seen people get upset about VSDs is not really about the VSD per se, but that what this might be an indicator of. And so I think that is where there is some dilemma, usually not so much the muscular ones, but more in the sort of perimembranous region. I mean, I think that the 2D is critical. The angle of intonation and image quality is absolutely critical. Multiple views, not looking at things with one view, but multiple views. And apart from the technical differences, there's color and there's color. We really should be in setups where we're using good color setups, trying to minimize color bleeding, because color bleeding can lead to overcalling. The only thing I'd make as an additional comment is that despite all the advances in ultrasound, I think some of the systems, the more post-processing that is put on the image, the more this perimembranous dropout seems to come up. And I think that is something that we should be, as a technical thing, really taking seriously, because I think some of the very, very new systems with really what look like lovely images sometimes produce more of this than some of the more maybe grainy type of images that we maybe were used to looking at in the past. And it's certainly very manufacturer dependent. That's definitely true as well. So
thank you.
Associations are the main fly in the ointment here.
Yeah, thank you.
Can I make one additional comment, John, about your comment? And Gerline and your people at Evelina, you know, in 1964, Dr. Rudolph and Hoffman wrote a paper on the natural history of VSDs. And I think that this paper needs to be extended into fetal life. And I don't have the resources to do that anymore, but certainly that's a very reasonable paper. And then, Rima, about your suggestion about color, the thing that is sort of, as a physiologist, a little bit of a dilemma to me is if the ventricular pressures are the same in the fetus, why are we looking for left to right or right to left shunts across ventricular septal defects? Why does this occur? And I found it interesting because ventricles don't contract simultaneously, and also the vascular resistances, not just the pressures, but the vascular resistances between the aorta and the pulmonary artery circulations are so different in the fetus. And so there's often a left to right shunt. And I think that the thing to look at when you see these left to right shunts is to actually look and see whether it's left to right in systole or right to left in systole. And that also will give you some idea not only of the vascular resistance of, but potential problems. As we were saying, if you see a 1.5 meter per second velocity across the aorta with a left to right shunt, you might consider that perhaps there is something unusual about that. So I think that, you know, all of this information becomes valuable, and by taking it, we will learn the situations of what is important to improve the diagnostic quality.
It's important. It's perhaps small VSDs are not important to us outcome-wise, but if you tell the parents that there's a suspicion of a small VSD, they don't sleep. They are so annoyed, especially if it's the only child or a precious or an IVF. So this is where the dilemma, at least to me and to other people, comes. Okay, we suspect a small VSD, and then medically speaking, it might not have a lot of impact, but for the parents, that's a trauma.
Always, when you tell the parents there's a problem, there's trauma, and I don't know how you can avoid that. I mean, you either, I mean, if you feel that you don't need to tell them and you can control them, maybe I think that that's a bad situation, because you get into an inaccurate diagnosis with the concealing of information. So I think you have to tell people what you feel, and then you have to give them insurances. I mean, if you see a small VSD, you know, you can tell them, look, we see many more of these, and I think this is true in utero than we see after birth. I mean, if you look at the natural history of VSDs in adults, for example, if you go to adult congenital clinics, VSD is the most common defect that we see in the neonatal period. Okay? I mean, it constitutes a huge amount of pediatric cardiology. And yet, when you look at adult congenitals, you hardly ever see patients with VSDs. So something's happening to those VSDs. There's an ongoing history of closure. And I think that this, you know, you need to tell the parents as well that, you know, that this is, if it's a muscular VSD, that we've just done a study to show that over 50% of those defects close in the early neonatal period. Perimembranous VSDs have got a much more significant presentation. So I think, you know, just have to tell the truth. I could never condone concealing information from the parents.
No, we don't conceal, but I'm saying the impact of saying we suspect a small VSD, it carries a lot of impact.
It also depends in counseling how you, okay, Jelani, in a second, but it also depends in counseling how you talk to parents. I mean, this is an important skill. You know, you need to be able to talk to parents honestly and with assurances and with the, you know, the weight of all your experience. That's it. I've got nothing else to say.
Jelani, sorry to keep you. Unmute yourself. Unmute yourself. Jelani.
I had to make a list here because so many things have been discussed and people are getting very enthusiastic about it. First, I agree with John. I think small VSDs, it doesn't matter if it's perimembranous or muscular. If you work in a fetal medicine unit where a large proportion of babies are referred because they are high risk of chromosomal abnormalities with increased nucleotranslucence and so forth, if you find a small VSD, may make a difference, perimembranous, for the family to decide to have an invasive test or not. So I think, you know, we do strive to try and exclude that as much as possible. I agree that if we miss it, and it doesn't matter, they will close, there's no hemodynamic implication. Two, about the color, I think the color for VSD is very important. You do see bidirectional shunting in muscular VSDs, it's typically bidirectional. And perimembranous, it depends, you know, if there is tricuspid valve, if there isn't. But I think color is essential, not only the conventional color. If you use the conventional color plus the high definition, because they do have different, you know, they show flow in a different way, and not only different angulations, but also doing it in a sweep. If you do a very slow sweep from 4-chamber to outflow tract, that is without color, with power Doppler, with whatever colors you've got, and that's why I think is important. I don't intend to say that I diagnose all small muscular VSDs. Sometimes you can't be 100% sure, but I think you can minimize the chance of overlooking small VSD that may have implications for the family, which are not cardiac. Two other things, post-processing, I agree with John, but I think, you know, the images are very smooth. We do get lots of referral query VSD when there isn't one, but I think it comes to the same. The machines have post-processing, they come with a preset. If you have to know your machine, you can turn them off. So if I have a question about a VSD that is, I just switch off, I turn down to the old quality picture of the analog systems where you don't have so much post-process and put color on top of that. And that minimizes as well, because you will see structures that the post-processing is smoothing out of the picture. So I think people need to know how to, not to just accept the preset that comes with their system, but to know how to turn it down, how to tune it down, or sometimes to switch it off completely, because you can do that.
Can 3D help?
I don't use 3D. I don't think so.
John?
Not in terms of making or unmaking the diagnosis. I don't think it doesn't have the resolution. I think 3D is helpful for some situations where the position of a VSD may be really important for management. So it's more like if there's a complicated, say, transposition or double outlet, where the position of a VSD might be, and size of a VSD may be critical towards management, it might have some help in selected cases, but not in terms of these ones now.
Dr. Silverman, do you think 3D imaging and post-processing and all the programs that they have can help? And we did see how MRI can help a lot in coarctation and also in difficult anatomies, and also now the 3D imprinting postnatally for surgery. How is it in 3D prenatal? Could it help?
I think it can help, as John has shown you very beautifully with the arch.
Yes, that's MRI. That's
I
3D
think
MRI.
that that's where it's helpful. I think as far as VSDs, that's not what I would think of using
No, but we could do it in the clinic. You can have a 3D machine and you put a live 3D and you try and do some cuts and color and post-processing.
I'm halfway between St. George's and Evelina in this situation. I think it helps sometimes.
Being political all the time. Okay. I'd like to thank.
Correct.
Yeah, I think
Not
critically
political.
correct. You are critically
Can I make
correct.
one more point, Rima?
Sure.
So I had 4 points here. The other one is about counseling. I think, I don't know how other people do, but if I have a small VST, be it muscular or perimembranous, I think you are correct that the word a little hole in the heart has a big psychological impact on the family. So whatever I see on the scan, be major or minor abnormality, I would always draw 2 pictures of the heart and show what a normal heart is. And before I explain what a VSD is, I said, this is what your baby has. All the structures, all the valves, all the vessels, all working well. So from that point, it happens to have a little hole. So at the end, I say, what you should remember is that everything else is fine. Yes, there is a little hole, but that's not the main message of the scan. So
And the other thing,
the positive message, they can't go away thinking, my baby has a hole in the heart. And also the press, at least in the UK, if a baby has a very complicated heart abnormality, it hits the press, it says, baby with a hole in the heart. Sometimes that baby has everything but a hole in the heart. It could be an isomerism, it could be a hypoplast. So is it psychological? You need to translate then the message that the message is, show them what the normal is, show that you've seen all the normal structures, they're all working well. Yes, there is a little hole, sometimes I even say, if, muscular VST, if I tell you your baby has to have a heart abnormality, pick one, because more muscular VST, because it doesn't matter. Yeah, so they feel happy with that.
Also, the way out is that the word that this is a heart it changes all the time. That it might close. I mean, even if it's small, if you're not sure, but next visit might not be there, and you can say with confidence it's not there. I think it's also reassuring to tell them that this heart is not yet finished. It's still developing. Is this correct? Do you agree to that statement to the parents?
If I see it with confidence, it's usually there after my second scan. If I doubt it, I may or may not see it. But if you see a muscular VSD in mid-gestation, clear color, bidirectional, you put a pulse wave, you can hear bidirectional shunting. In my experience, when I scan them again 32, 34 weeks, the VSD is there in almost 100% of the case.
Of course, experience. We have a lot of experienced cardiologists today. And I'd like to thank all 3 speakers from the UK with a tremendous background and various degrees of imaging. We did see, actually, it's like a complete syllabus today of how people handle different lesions. Thank you again. I'd like to thank our mentor and our dear guest all the time, Dr. Silverman. I'd like to thank Sasha, who had to leave. He's the president of Congenital Heart Academy. He's a cardiac surgeon from Italy, who's really helping us a lot in this series. I'd like to thank all our attendees. We had like 250 attendees today, and we're very grateful for all the comments from all the world. And if you're interested, you can still watch this webinar online on the YouTube under Fetal Series Congenital Heart Academy. Thank you, thank you, thank you again and again.
Thank you, Raymond. Thank you, Anne.
Thank you very much.
Thanks.
Well,
Thanks very much.
Thank you very much, everybody.
Thank you, everyone.
Have a good evening, everyone.
Thank you.
Bye. Bye.
Great job, everybody.